So the second patient is a pregnant woman with complex adult congenital heart disease. So she's a young lady, 24 years old, with an original congenital diagnosis of pulmonary septum with atresia with intact ventricular septum. She underwent multiple surgical procedures during her childhood since birth until the age of 12 years. She status post multiple complex open heart surgeries, ventricular repair, and surgical replacement of regurgitant pulmonary valve at the age of 12. So this is just a demo for the congenital cyanotic heart disease that she was born with. So the pulmonic artery is atretic and closed, so this will create a cyanotic heart disease. And here the patent ductus arteriosus is helping at the early days of life in maintaining the pulmonary systemic circulation. And there is an ASD defect as well. And the surgical repair for this procedure is basically, they call it a Glenn procedure, where they put a shunt between the aorta and the pulmonic trunks. So patient presented for baseline assessment. So initial ECG at presentation, it was basically normal, only showing incomplete right bundle branch block, otherwise sinus rhythm and normal ECG. And basic cardiovascular exam is reassuring as well, with no cyanosis, clubbing, or peripheral edema, and JVP was not elevated, and chest was clear to auscultation with no evidence of ascites or edema, and no pathologic murmurs identified. Part of the basic screen also for such patients who are adults with history of cyanotic congenital heart disease is to do a baseline echocardiography, which showed a patent Glenn anastomosis, normal biventricular size, and the ASD device is seen inside without any residual leak, and she was having normal pulmonary artery flow. She underwent also a stress testing. So resting ECG was showing normal sinus rhythm, and she was able to complete exercise using Bruce protocol and achieved 83% of maximum predicted heart rate with fair functional capacity and reassuring parameters of in the ECG and the hemodynamics. 48 hours Holter monitor was also conducted, and it also showed no significant atrial or ventricular runs. So that was also reassuring. Now the patient was planned for cardiac MRI, but she got pregnant with spontaneous pregnancy with a singleton fetus, and this was her first pregnancy. So at this stage, she continued to follow up with adult congenital heart disease clinic and cardio-obstetric clinics. So pre-considerations in this case are for pre-pregnancy counseling in order to complete a full workup and get a full picture of her cyanotic heart disease. Risk assessment, including assessment of her NYHA class for heart failure, assessing the ventricular function and presence or absence of pulmonary hypertension. Monitoring with echocardiography per trimester is indicated, and fetal growth scans and monitoring of intrauterine growth restrictions is also important. So she had an echocardiography done in her third trimester. Stable aortic root was there. PFO closure was stable. No significant valve disease. So she was basically doing well during her pregnancy, and no concerning echocardiographic features. So the patient was found stable and fit for normal vaginal delivery, as she was hemodynamically stable, the echo was reassuring, and she wasn't having any features of heart failure or pulmonary hypertension. She developed late onset proteinuria, but BP remained stable, liver function was stable, but the decision was to deliver by spontaneous vaginal delivery at 38 weeks plus 3 days. And the anesthesia team were on board, and they assisted with the delivery by epidural anesthesia, and the delivery went well without any complications. So after care, patient received counseling for contraception, and pre-pregnancy counseling is recommended if there is any plans for future pregnancies. This is just a chart to guide in assessing and managing women with complex congenital heart disease in case of pregnancy. So it is important to collect very good history and physical examination and to see if the patient is having any complications by the measures that I mentioned earlier, ECG, stress testing, and cardiac MRIs, and genetic testing if indicated. And based on the assessment, the patient can be classified either stable for spontaneous vaginal delivery, or if there is any signs of cyanosis or complications, then depending on the severity, the judgment whether she is safe to continue with the pregnancy or termination is the appropriate answer here, and whether the delivery mode is spontaneous delivery or by C-section. So yeah, risk assessment and pre-pregnancy counseling, monitoring, and multidisciplinary care is important in patients with cyanotic congenital heart disease going for pregnancy. So this is my second case. Thank you very much. If you have any questions.